Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Welcome to the Deep Dive. Today we're diving into something that, well, it might genuinely surprise you. When I mention the world's deadliest animal, what flashes through your mind? Maybe a great white shark, a roaring lion, something powerful like a grizzly bear. Most people think big predators, right? But the truth is, the creature responsible for more human deaths than any other is much, much smaller. Often goes unnoticed, actually, until it's too late. We're talking about the mosquito. Yep, that tiny buzzing insect. It's at the heart of a truly global health crisis, and it's one that's being rapidly, amplified by the changing world around us. So our mission today is to unpack the sheer scale of this threat. We want to understand the intricate biology that makes mosquitoes such effective vectors, and then really zero in on those intersecting global forces, climate change, rapid urbanization, increased human mobility that are making a complex problem even worse. We'll examine the strategies we currently have to fight back, look at the formidable challenges they face, and crucially, look at real-world examples, ones that show us where we're most vulnerable, but also where there's, genuine hope for a more resilient future. Because this isn't just about obscure tropical diseases somewhere far away. It's about a complex, evolving challenge that, frankly, demands a new way of thinking about global health and our place in it. We've set the stage talking about this tiny but, terrifying threat. So let's get right into it. Just how deadly is the mosquito? What are the numbers? Let's make this sink in.
It's a staggering picture, really. Globally, mosquitoes are responsible for an estimated 700 million infections.
That's 700 million?
Yes, and over 1 million deaths annually.
Wow.
To put that in perspective, that's nearly 1 in every 10 people on the planet directly affected by mosquito-borne illness each year.
That's a truly astonishing figure. And what strikes me about that number, it's not just a biological fact, is it feels like it points to something, deeper.
It absolutely does. A mosquito thriving in stagnant water from overflowing trash or transmitting disease rapidly through a densely populated, unplanned urban area.
Yeah.
And it isn't just a biological problem. It's a glaring symptom of profound systemic failures.
Okay.
Breakdowns in public health infrastructure, inadequate environmental stewardship, deep socioeconomic inequities. The thing is, these diseases are, to a large extent, preventable and treatable.
Right.
Which makes that death toll even more tragic. It really forces us to ask, where are our systems truly failing?
And the basic mechanism of transmission that's critical to understanding how we even begin to fight them. Can you walk us through that, maybe from the mosquito's point of view?
Sure. So it all begins when a female mosquito, and it's always the female, she needs the protein for egg production, takes a blood meal from an infected host.
Okay.
She ingests the pathogen, whether it's a virus or a parasite. That pathogen then replicates inside her, migrates from her gut to her salivary glands. Then when she takes her next blood meal from a new, uninfected host, she injects that pathogen along with her saliva, completing the cycle.
Simple but deadly.
Very. And when we talk about this global burden, there are really 3 big mosquito groups responsible for most of it. You've got Anopheles, the primary vector for malaria, then Aedes, which carries dengue, Chikungunya, Zika, and yellow fever, and Culex, which is known for West Nile virus and several forms of encephalitis.
So connecting this back to the bigger picture, what conditions are these diseases really thriving in?
Right. They thrive in specific conditions that are unfortunately very widespread. We're talking about things like stagnant water from inadequate sanitation systems, poor waste management, leading to, discarded containers everywhere, improper water storage.
And these conditions aren't random, are they?
No, exactly. These are issues disproportionately prevalent in communities with lower socioeconomic status. It really reveals why purely biomedical solutions, like drugs or vaccines, while absolutely essential, just aren't enough on their own. We have to concurrently address the root drivers, like poverty and inadequate infrastructure.
Okay, now let's turn our attention to the specific illnesses themselves. There are quite a few. Maybe we start with an ancient enemy, one that continues to plague millions.
Malaria is the obvious one to start with. It's caused by Plasmodium parasites, and P. falciparum is the most virulent, the most deadly strain, transmitted by Anopheles mosquitoes.
And the symptoms.
The classic symptoms are cyclical fever, chills, and sweats. Almost like clockwork, they come and go. But it can rapidly escalate. Severe complications like cerebral malaria, severe anemia, organ failure. These can be fatal very quickly.
And where is it most prevalent?
It predominantly affects tropical regions, especially the WHO African region. That's where the vast majority of deaths occur. But, and this is important, it's worth remembering that Anopheles mosquitoes, the vectors, are still present in places like the US and Europe.
Really? Still here?
Oh, yes. Which means there's that persistent risk of reintroduction, even in areas we might think of as safe.
Right. So while malaria has been this devastating force for centuries, there's a newer wave of viral threats spreading with, well, alarming speed.
Yeah.
And bringing unique challenges. Let's delve into those.
Yeah, dengue is a big one here. It has emerged as the fastest spreading mosquito-borne viral disease globally. Period.
Fastest spreading. Wow.
It's caused by the dengue virus, DENV, which actually has 4 distinct serotypes or strains, primarily transmitted by Aedes aegypti. That's a highly urbanized mosquito. It loves breeding in artificial containers around homes, flower pots, old tires, you name it.
Urban specialists.
Exactly. And also Aedes albopictus, sometimes called breakbone fever because of the severe joint and muscle pain it causes. And severe dengue, that can be life-threatening. We see plasma leakage, severe bleeding, organ impairment. A critical risk factor for getting severe dengue is actually having a secondary infection, but with a different serotype than the first time.
So getting it again can be worse.
Potentially much worse, yes. It's now endemic in over 100 countries, putting over half the world's population at risk. Asia accounts for about 70% of the global burden.
Okay, next up. West Nile virus, WNV. This one stands out to me because of its unique transmission cycle. Tell us about that.
Right. West Nile is interesting. It's a flavirus, primarily transmitted by Culex mosquitoes, and it's maintained in nature in a cycle between mosquitoes and birds. Birds are the main reservoir hosts.
Okay, so birds are key.
Very key. Humans and horses, actually, are what we call dead-end hosts.
Meaning
We typically don't develop high enough levels of the virus in our blood to infect new mosquitoes if they bite us. So we get sick, but we don't really contribute to spreading it further in the cycle.
Okay. Small comfort, maybe.
A small comfort, perhaps. Most human infections, maybe up to 80%, are actually asymptomatic. You wouldn't even know you had it. About 20% of people develop West Nile fever, mild flu-like symptoms, but less than 1% develop severe neuroinvasive disease like encephalitis or meningitis that can cause permanent neurological damage or even death.
And this is common in North America.
It's been the leading cause of domestically acquired arboviral disease. That means mosquito-borne viral disease acquired locally in the U.S. and Canada since its unexpected introduction back in 1999.
Right, I remember that. Okay, now Zika virus, ZIKV.
Right.
Another flavivirus. This one gained widespread notoriety not too long ago. What makes it particularly significant?
Well, Zika is primarily transmitted by Aedes mosquitoes, same ones as dengue, often known for their aggressive daytime biting habits. But what really distinguishes Zika and causes so much alarm are its non-vectorial transmission pathways.
Meaning not from a mosquito bite.
Exactly. Most notably, sexual contact and, crucially, maternal-fetal transmission during pregnancy. While most infections are asymptomatic or mild for the infected person, the profound public health importance stems from congenital Zika syndrome.
That's the microcephaly link.
Yes, causing microcephaly, abnormal small heads, and other severe birth defects in babies born to infected mothers. It's also been linked to Guillain-Barré syndrome, a neurological condition in adults. Its explosive spread throughout the Americas in 2015-2016 really changed our understanding of arbovirus transmission and its potential consequences.
Okay, let's talk about yellow fever virus, YFV. This one has a long history, and there's even a vaccine, right?
That's right. Yellow fever is another flavivirus transmitted by Aedes mosquitoes, but also Haemogogus species in jungle settings. It actually has 2 main cycles, a jungle cycle involving non-human primates and an urban cycle involving Aedes aegypti in humans.
Okay.
Initial symptoms can be mild fever, headache, muscle pain, but about 15% of symptomatic patients enter a more dangerous toxic phase. This is often marked by jaundice, that characteristic yellowing of the skin and eyes, hence the name, along with abdominal pain, vomiting, and bleeding.
And the outcome of that phase?
Sadly, up to half of those who enter the toxic phase die within about 7 to 10 days. It's very serious. The good news is a highly effective vaccine has been available since the 1930s. It provides lifelong immunity.
So why do we still see outbreaks?
Outbreaks still occur in areas, primarily in Africa and South America, with low vaccination coverage. It really underscores the importance of sustained public health campaigns and vaccine access.
Right. And finally, Chikungunya virus, CHIKV. The name itself, to become contorted, tells you something about this one, I imagine.
It really does. Chikungunya is an alpha virus, transmitted again by Aedes aegypti and Aedes albopictus. It's characterized by an abrupt onset of fever and severe, often debilitating joint pain. That's where the name comes from. The pain can be excruciating, causing people to contort.
Does it last?
While the acute illness typically resolves in weeks, the chronic joint pain can persist for months or even years. This leads to significant long-term disability for many people. Historically, it was mostly confined to Africa and Asia, but the virus adapted somehow around 2004, which led to explosive global spread. It hit the Americas hard, starting in 2013.
So hearing about all these dengue, Zika, chikungunya, what really jumps out is this concept you mentioned, the diagnostic fog. They often circulate in the same areas, carried by the same mosquitoes, and the initial symptoms sound almost identical. That must be a massive challenge on the ground.
It's a critical issue, a huge challenge. Imagine a pregnant woman comes in with fever, aches. Is it Zika? Is it dengue? If it's Zika and it gets misdiagnosed as dengue, that crucial counseling opportunity about the risks of microcephaly is tragically lost. Or flip it around. If a dengue outbreak is brewing, but cases are being misclassified as chikungunya, which maybe seems less urgent, the necessary public health response vector control alerts can be dangerously delayed.
So the numbers we see might be completely wrong.
Exactly. This diagnostic fog means official statistics are often vast underestimations. It masks the true burden of each specific disease, it hinders accurate forecasting, and it severely complicates resource allocation. We urgently need rapid, affordable, multiplex diagnostic tests that can tell these apart quickly at the point of care. Otherwise, like you said, we're fighting an enemy we can only partially see.
Beyond the individual symptoms, which are bad enough, these diseases impose just a staggering, multifaceted burden. It's not just health, is it? It's economic society.
Absolutely. Quantifying the full burden is tough, partly because of surveillance limitations we just discussed, but the picture we have is grim. Mosquito-borne diseases, taken together, are responsible for more than 17% of the global burden of all infectious diseases.
Wow, 17%.
Yeah. Every year, they cause hundreds of millions of cases and lead to over 1 million deaths. That makes them a leading cause of preventable illness and death worldwide.
Let's try to put some numbers on that. You mentioned malaria earlier.
Right. For malaria, the WHO reported 249 million cases and 608,000 deaths in 2022 alone.
Good grief.
And the vast majority of those deaths are young children in sub-Saharan Africa. Globally, 3.2 billion people are considered at risk.
And dengue, you said it's spreading fast.
Incredibly fast. The reported incidence has increased more than tenfold just since the year 2000. Back then, it was maybe 500,000 reported cases globally. In 2023, over 6.5 million cases were reported, with over 7,300 deaths.
That's a huge jump.
It is. But here's the real kicker. Those are just the reported cases. Epidemiological models estimate the actual number of dengue infections annually is closer to 390 million.
390 million compared to 6.5 reported.
Exactly. It's this massive underreporting iceberg. The 6.5 million reported cases are truly just the tip, this huge, largely invisible reservoir of infected individuals, many of whom are viremic and capable of transmitting the virus even if they have mild symptoms, makes outbreak control exceptionally difficult.
Right.
It really highlights the need for proactive, population-level interventions, not just reacting when hospitals fill up. We're constantly battling unseen threats.
And what about the economic impact? You mentioned billions earlier.
Absolutely. The aggregate cost of just mosquito-borne diseases is estimated at least US $12 billion per year.
Just these diseases?
Just these. Dengue alone was estimated around $8.9 billion annually back in 2013. The Zika epidemic was estimated similarly, maybe $8.9 billion impact. Malaria costs were around $4.3 billion in 2016. These are immense sums.
That's huge. But this raises a really important question for all of us listening. Who truly bears the brunt of this immense economic cost? What does this mean for the lives of ordinary people in affected regions?
That's such a critical point, because while we see these large, almost abstract dollar figures, the cost is really felt most acutely at the individual and household level, especially by the poor.
How so?
Well, in many low and middle-income countries, health systems might be weak, social safety nets might be non-existent. So a single episode of malaria, for example, can consume a huge portion of a family's annual income. Studies have shown up to 25% in some cases.
A quarter of their yearly income gone to one illness.
Exactly. It's hard for us to truly grasp what that means. That's not just a temporary setback. It's often a profound, lasting blow. It can force families to sell assets, take children out of school, go into debt. It ripples through generations. It pushes families deeper into poverty. And it perpetuates this vicious cycle where poverty creates the conditions for disease, and then the illness itself deepens that poverty. It's a stark reminder of those systemic inequities we talked about earlier.
Right, and this escalating crisis, it isn't happening in a vacuum, is it? It's being actively fueled by this complex interplay of environmental and social changes, mostly driven by human activity. You called it a perfect storm.
It truly is. Let's start with climate change. It acts as a massive threat multiplier. Mosquitoes are cold-blooded, right? So their basic life processes, development, reproduction, activity, are highly sensitive to temperature. So warmer global temperatures do a few things. First, they allow mosquitoes to expand their geographic range into previously colder regions, places they couldn't survive before. Second, higher temperatures actually accelerate the mosquito's entire life cycle. They grow faster, reproduce faster. This leads to larger populations in a shorter amount of time.
More mosquitoes, faster.
Exactly. Third, the heat increases their biting frequency. Studies show a mosquito might bite, say, 3 times as often at 30 degrees Celsius compared to 20 degrees.
Wow.
And crucially, fourth, it shortens something called the extrinsic incubation period, or EIP.
What's that?
That's the time the pathogen, the virus or parasite needs to develop inside the mosquito before it can actually be transmitted in the next bite. Warmer temperatures shorten this EIP, which means the mosquito becomes infectious faster, leading to more efficient disease spread, faster transmission.
And it's not just the steady heat, right? Extreme weather events play a role too?
Oh, absolutely. Heavy rainfall and flooding, obviously, create numerous pools of standing water, perfect breeding sites for many mosquito species. But paradoxically, prolonged droughts can also increase vector breeding, especially for urban mosquitoes.
How does that work?
Well, as natural water sources dry up, communities are often forced to store water in open containers, barrels, buckets, tanks.
Creating artificial habitats.
Precisely. Inadvertently creating ideal habitats for domestic mosquitoes like Aedes aegypti, right where people live. And things like milder winters and longer, warmer summers also extend the transmission season for these diseases in many temperate regions. The window for outbreaks just gets longer.
And the projections for the future, you said they're concerning.
They are severe. Some epidemiological models predict that by 2070, an additional 4.7 billion people could be living in areas at risk from these diseases.
An extra 4.7 billion.
Yes. And many of these people will be in areas where populations haven't been exposed before, meaning they have no immunity, and where public health systems are completely unprepared for these kinds of threats.
So, while climate change is redrawing the map of potential transmission, it's the landscape of human settlement, especially this rapid, often unplanned urbanization that creates the localized conditions for these explosive outbreaks. How do cities contribute specifically?
Cities, especially rapidly growing ones in tropical and subtropical regions, provide an almost ideal ecosystem for human-loving or anthropophilic vectors like Aedes aegypti.
How so?
They thrive in all those artificial water-holding containers we mentioned, discarded tires, plastic trash, flower pots, blocked gutters. They're everywhere in urban environments. Plus, high human population density means a constant, readily available supply of blood meals. This facilitates incredibly rapid person-to-mosquito-to-person transmission cycles.
And the risk isn't spread evenly across the city, is it?
No, definitely not. Poverty, lower quality housing, inadequate public infrastructure, these areas are often the epicenters of transmission. Think about unreliable municipal water supplies, forcing water storage, inconsistent waste collection leading to more containers, poorly constructed housing, offering more entry points and resting places for mosquitoes. All these factors directly increase mosquito densities and the amount of contact between humans and vectors.
Creating that cruel feedback loop you mentioned.
Exactly. Poverty fosters the environmental conditions for disease, and then the economic burden of the illness digs that poverty trap even deeper.
What really struck me is how these factors don't just add up, they multiply.
Yeah.
The synergy you mentioned must make this challenge even more complex, right?
Absolutely. Climate change and urbanization don't act in isolation. They powerfully amplify each other. Take the urban heat island effect, for instance. Cities are often significantly warmer than surrounding rural areas. This local heat boost can further accelerate mosquito and pathogen development rates, right where the most people live. Or consider a drought, made worse by climate change. It forces dense urban populations to store water, leading to a massive surge in Aedes breeding sites, which can then trigger a major outbreak. It's a combined effect.
Which means our old ways of predicting risk, They're probably becoming obsolete.
Precisely. Public health authorities can no longer just rely on past patterns or historical risk maps. The game has changed. The unprecedented dengue epidemic in Brazil in 2024, that was fueled by the powerful El Niño climate pattern, acting on top of existing vulnerable urban environments with large vector populations. It's a stark, devastating, real-time example of this dangerous synergy in action, a living lesson in how these global drivers combine to create new levels of crisis.
Okay, so given all this, what are we actually doing about it? Combating this clearly requires a multi-front war, right? Against both the mosquito and the pathogen.
That's right. For decades, the mainstays were chemical insecticides, things like indoor residual spraying, IRS, where you spray walls, and insecticide-treated bed nets, ITNs. Larviciding, too, killing larvae in water. And they were incredibly successful, especially against malaria. They dramatically reduced the burden in many parts of the world.
What? There's always a but.
There is. The very success of these chemical tools led directly to their greatest challenge, the evolution of insecticide resistance.
The arms race against evolution you mentioned. Tell us more about that.
It absolutely is an arms race. Heavy, prolonged reliance on just a few classes of insecticides has put immense selective pressure on mosquito populations. This has led to widespread resistance developing in Anopheles, Aedes, and Culex mosquitoes all over the world.
How does the resistance work?
Mosquitoes evolve resistance in a couple of main ways. One is metabolic resistance, where they develop enzymes that can break down the insecticide chemical before it does harm. The other is target site resistance, where mutations occur in the specific proteins in their nervous system that the insecticide is supposed to attack, so the chemical can't bind properly anymore.
So the insecticide just doesn't work as well or at all.
Exactly, which means public health programs must actively monitor resistance. They use tools like the CDC bottle bioassay, basically, exposing mosquitoes to known concentrations of insecticide to see if they survive.
Like mini diagnostic tests for mosquito populations?
That's a good way to put it. Without this monitoring, we'd be fighting blind, potentially wasting millions on insecticides that no longer work in a particular area.
So it sounds like we can't just solve resistance, we have to manage it constantly.
Precisely. Managing resistance isn't about finding a permanent solution, but continuously adapting. Strategies include rotating between different insecticide classes that have different modes of action, so you're not always hitting them the same way, using combinations of insecticides, sometimes even trying to maintain refugia areas where susceptible mosquitoes can survive to hopefully dilute the resistance genes in the wider population.
Interesting.
But most importantly, it means fundamentally reducing our reliance on chemicals by integrating non-chemical methods like environmental management, clearing breeding sites, improving sanitation, because ignoring resistance leads to catastrophic control failures, wasted resources, and ultimately an increase in disease transmission and human suffering.
Okay, chemicals are facing challenges, but there's a fascinating new frontier emerging in this battle. Novel biological controls, what's happening there?
Yes, this is really exciting. One of the most promising and, importantly, field-tested innovations involves a bacterium called Wolbachia. Now, Wolbachia is a naturally occurring intracellular bacterium found in many insects, but crucially, not naturally in the main dengue vector, Aedes aegypti.
Okay.
When scientists artificially introduce Wolbachia into Aedes aegypti mosquitoes in the lab and then release them, it has two remarkable effects. First, it dramatically reduces the mosquito's ability to get infected with and then transmit a whole range of arboviruses, dengue, Zika, chikungunya, yellow fever.
It makes them less infectious.
Essentially, yes. It's like it boosts the mosquito's immune system against the virus or directly competes with the virus for resources within the mosquito's cells. And second, Wolbachia has this fascinating reproductor effect called cytoplasmic incompatibility, or CI.
CI, what's that?
Basically, if a male mosquito infected with Wolbachia mates with a female mosquito who is not infected, her eggs just won't hatch. They're not viable. But if an infected female mates, her offspring inherits the Wolbachia and survive. This gives the infected mosquitoes a reproductive advantage.
Clever. So how is this used?
It allows for two distinct control strategies. One is population replacement. You release both male and female Wolbachia-infected mosquitoes. Because of CI and maternal inheritance, the Wolbachia spreads through the wild population over generations, eventually replacing the original population with mosquitoes that are largely unable to transmit disease.
Self-sustaining, you mentioned.
Exactly. It's self-sustaining and environmentally friendly because you're not killing mosquitoes, just modifying their ability to transmit disease. The other strategy is population suppression. Here, you release only Wolbachia-infected males. They mate with the wild, uninfected females, but because of CI, those eggs don't hatch. If you release enough males over time, you can cause the local mosquito population to crash.
That sounds incredibly promising. You mentioned the World Mosquito Program. Tell us more about how they've pioneered this and the impact it's having.
Yes, the World Mosquito Program has truly been at the forefront of the population replacement strategy. They've conducted large-scale deployments in numerous countries. For example, in Niterói, Brazil, a city we'll discuss more in a case study, they've achieved remarkable sustained reductions in dengue cases after releasing Wolbachia mosquitoes starting back in 2015. It's really compelling evidence.
That really does sound like a potential game changer. Are there any potential downsides or challenges with Wolbachia?
Well, like any new technology, there are things to monitor. There's a theoretical risk, though not yet observed in the field, that viruses could eventually evolve to overcome the Wolbachia blocking effect, and its effectiveness can be somewhat temperature sensitive. Very high temperatures during the mosquito's larval development can sometimes reduce the density of Wolbachia in the adult mosquito, which might slightly reduce the blocking effect. So local climate matters. But overall, the results have been incredibly positive.
Okay. Another novel approach we hear about is genetic modification, or GMMs, mosquitoes engineered in the lab. How does that work?
Right. Genetically modified mosquitoes typically involve engineering male mosquitoes with a specific gene, often called the self-limiting gene. The idea is that when these engineered males are released and mate with wild females, the offspring inherit this gene, which causes them to die before reaching maturity, usually at the larval or pupal stage.
So it's another way to suppress the population.
Exactly. Sustained releases of these GMMs can, in theory, drastically reduce the local mosquito population. Companies like Oxitec have developed and tested this technology. However, public perception, concerns about releasing genetically modified organisms and navigating complex regulatory hurdles have significantly slowed the widespread adoption of GMMs, despite promising results in field trials.
Understandable challenges. Okay, finally, let's talk about the ultimate goal for many infectious diseases. Vaccines, the elusive panacea maybe, they seem like the ideal tool, but you mentioned formidable hurdles.
They really do face significant hurdles, scientifically, economically, logistically. It's not easy. Let's take dengue first. The biggest challenge, as we touched on, is the existence of those 4 distinct serotypes, DNV1 to DNV4. An effective vaccine needs to provide strong, balanced protection against all 4 simultaneously. Why? Because of that dangerous phenomenon called antibody-dependent enhancement, or ADE.
Right, where having antibodies from a previous infection or maybe a vaccine against one type can actually make a subsequent infection with a different type more severe.
Exactly. It's like the immune system's response backfires. This ADE risk has haunted dengue vaccine development for decades. The first licensed vaccine, Dengvaxia, showed this effect. It protects well if you've already had a dengue infection, but it can increase the risk of severe dengue if given to someone who's never been infected before.
So its use is restricted now?
Yes. It's now generally recommended only for individuals living in endemic areas who have confirmed evidence of a prior dengue infection, which complicates rollout. Newer vaccines like Qdenga and Butantan DV are showing promise in providing broader protection with potentially less ADE risk, but it's still a major consideration.
Okay, what about malaria? Why has a truly effective malaria vaccine been so hard to develop?
The Plasmodium parasite that causes malaria is incredibly complex. It has a multi-stage life cycle, spending time in the human liver and red blood cells, and it's genetically very diverse. It's a master of disguise, constantly changing its surface proteins to evade the human immune system.
A very tricky target.
Extremely tricky. After decades, literally decades, of intensive research, the first malaria vaccines, RTS, S01, Mosquitoes, and more recently R21 Matrix M, have been developed and recommended by the WHO. This is a landmark achievement, truly. But they offer only partial protection, maybe reducing clinical malaria episodes by 30–50% in young children, and they require multiple doses, typically 4 shots in the first couple of years of life.
So helpful, but not a silver bullet yet.
Not yet. They're valuable tools, especially when combined with bed nets and other measures, but we still need more effective, longer-lasting vaccines.
And are there general challenges across the board for developing vaccines against these kinds of diseases?
Yes, there are. Often there's a lack of good animal models that accurately replicate the human disease, which makes preclinical testing difficult. Sometimes we have an incomplete understanding of exactly what type of immune response, which antibodies, which T cells, truly protects against infection or disease. And economically, vaccine development is incredibly long, risky, and expensive. There's often a perceived market failure because many of these diseases primarily affect low-income countries, making it less attractive for purely commercial development.
Do you need other mechanisms?
Exactly. That's where things like public-private partnerships, advanced market commitments, and funding from organizations like Gavi, the Vaccine Alliance, become absolutely essential to incentivize and de-risk the development and rollout of these crucial vaccines.
Right. Okay, the theory, the science, the challenges. They all converge in real-world crises. Let's look at two recent, very stark examples that really bring this home.
Let's start with a case study. The 2024 dengue epidemic in Brazil. This was by far the most severe dengue epidemic in Brazil's recorded history. By June 2024, the country had registered approximately 6 million probable cases. That's just a staggering number. And over 4,000 confirmed deaths.
6 million cases.
Yeah. The national healthcare system was pushed absolutely to its breaking point. Emergency rooms were overwhelmed, hospitals were full, temporary field hospitals had to be set up in some cities. It was a truly devastating public health emergency.
And why was it so particularly bad? What was the specific combination of factors that fueled this unprecedented crisis?
It really was that perfect storm we talked about. First, climate played a huge role. The powerful 2023-2024 El Niño climate pattern brought abnormally high temperatures and periods of extreme rainfall across much of Brazil. These are ideal conditions for Aedes aegypti mosquitoes to proliferate rapidly.
El Niño strikes again.
It does. Second, there was the virology factor. For the first time in quite a few years, all 4 dengue serotypes were circulating simultaneously in many areas, including a significant resurgence of DNV3, a serotype that hadn't been dominant for a while.
Meaning less immunity in the population.
Exactly. A large portion of the population lacked specific immunity to DNV3, making them highly susceptible. And finally, urbanization and socioeconomics provided the fuel for the fire. The epidemic raged most intensely in Brazil's densely populated urban centers. These areas often have long-standing issues with unplanned development, inequality, things like unreliable water supplies forcing storage, inadequate waste management creating breeding sites, poor housing conditions.
All fertile ground for Eads.
Precisely. It's a clear, tragic example of how those systemic failures and environmental vulnerabilities we discussed earlier manifest in a massive health crisis.
But amidst this truly devastating national crisis, there was a remarkable beacon of hope, wasn't there? The city of Niterói, which is near Rio de Janeiro. It stood out.
It really did. While the rest of the state and much of the country was seeing record-breaking dengue numbers, Niterói reported its lowest dengue incidence in decades. It was a striking positive exception.
And why? What made Niterói different?
This success is widely credited to their pioneering, citywide implementation of the World Mosquito Program's Wolbachia population replacement strategy. Remember, they started releasing Wolbachia mosquitoes back in 2015.
So the Wolbachian mosquitoes took hold?
Yes, and as a result, studies show that between 2020 and 2023, Niterói experienced a greater than 90% reduction in dengue cases compared to the pre-intervention period. This effectively shielded its population of about 500,000 people from the worst of the national epidemic that was raging all around them.
Wow.
It's truly compelling real-world evidence. It shows how these novel biological controls, when implemented systematically and sustained over time, can make a profound difference, even in the face of extreme climate events and viral circulation.
That's incredible. Okay, now let's bring it closer to home for many of our listeners, particularly those in North America. Case study. The return of local malaria transmission to the United States in 2023. For the first time in 2 decades, we saw locally acquired mosquito-transmitted malaria cases detected right here in the U.S. Not imported cases, but local spread. 9 cases across Florida, Texas, and Maryland.
That's right. And it immediately begs the question, how did this happen after 20 years without local transmission? It followed the classic pathway for malaria reintroduction into a non-endemic area. Step 1. An international traveler gets infected with malaria abroad in an endemic country. Step 2. That infected person travels to the U.S. while the parasites are still circulating in their blood. Step 3. While here, they get bitten by a local Anopheles mosquito. And as we discussed, the U.S. still has populations of Anopheles mosquitoes that are competent vectors, meaning they can transmit malaria. Step 4. The parasite develops inside that local mosquito, the EIP. Step 5. That now infectious local mosquito bites another person, a local resident who hasn't traveled, transmitting the parasite and causing a locally acquired infection.
So the chain was completed domestically.
Exactly.
And this event, even though it was only 9 cases, which seems small compared to global numbers, it highlighted several key vulnerabilities for the U.S., didn't it?
It absolutely did. First, as mentioned, vector presence. Competent Anopheles mosquitoes are still widely distributed across many parts of the U.S., particularly the east and south. The vector is here. It's usually just the parasite that's missing to start the cycle.
Okay.
Second, global travel. The U.S. sees around 2,000 imported travel-related malaria cases each year. People bring in the parasite back with them. The surge in international travel after the COVID-19 pandemic likely increased the number of these seed infections arriving, just statistically raising the probability of an infected person encountering a competent local vector at the right time.
Makes sense.
And third, climate change. Warmer, more humid conditions, especially in the southern U.S., create a more favorable environment for Anopheles mosquitoes to survive, reproduce, and extend their active season. And crucially, as we discussed with EIP, higher temperatures also accelerate the development of the Plasmodium parasite inside the mosquito. This shortens the time it takes for the mosquito to become infectious, making successful transmission more likely after biting an infected person.
So even though West Nile virus is still by far the most common locally transmitted mosquito-borne disease in the U.S., thousands of cases versus 9, these malaria cases feel like more than just a statistical blip. What do they signal big picture?
They function as a sentinel event, a warning signal. More than just the numbers, it signals that the epidemiological boundary, that invisible line we might imagine separating so-called tropical diseases from wealthier, temperate nations, is becoming increasingly permeable. It's blurring. It's a harbinger of what could happen more frequently, not just with malaria, but potentially with other diseases like dengue or chikungunya, whose Aedes vectors are also expanding their range northward due to climate change and human activity. It clearly shows that even wealthy nations aren't immune to the direct health impacts of climate change and globalization. It underscores the need to reinvest in and maintain robust domestic surveillance systems and vector control infrastructure capabilities that perhaps were thought necessary only in the tropics in past decades. It's really a warning shot for global preparedness, including preparedness at home.
The evidence seems crystal clear then. The era of trying to combat mosquito-borne diseases with sort of siloed, static, purely reactive interventions, that era is over. We need a new paradigm.
Absolutely. This complex, adaptive, interconnected threat demands an equally dynamic, integrated, and proactive response strategy. And that's really where the One Health framework comes into play.
One Health. We hear that term more often now. What does it mean in this context?
One Health is essentially a collaborative, multisectoral, and transdisciplinary approach to health. It explicitly recognizes the inextricable links between the health of people, the health of animals, both domestic and wild, and the health of the wider environment they share. It's about understanding that these three pillars are interconnected, and you can't effectively protect one without considering the others.
And what strikes me is that vector-borne diseases seem like the absolute quintessential One Health issues, don't they?
They absolutely are. You could argue they are the poster child for One Health. Why? Because their transmission cycles inherently involve pathogens existing and moving at the interface between human hosts, often animal reservoirs like birds for West Nile or primates for yellow fever, and the environment, which dictates the entire life cycle, abundance, and distribution of the mosquito vector itself. You simply cannot separate these components.
So how does implementing One Health actually work on the ground? What does it look like in practice, say, for controlling West Nile virus?
Well, it means breaking down those traditional silos we often see between different agencies and disciplines. So for West Nile control, it's not just physicians in hospitals treating the human cases after they occur. It's also ornithologists and wildlife biologists monitoring bird populations for die-offs or testing dead birds, serving as an early warning system that the virus is amplifying in the animal reservoir.
Okay.
It's entomologists systematically trapping and testing mosquito populations to see which species are present, how abundant they are, whether they're carrying the virus, and if they're resistant to insecticides. It's municipal authorities, like public works or water management departments, actively managing stormwater drainage and eliminating stagnant water sources to reduce mosquito breeding sites. It's veterinarians monitoring horses, which are also susceptible. And it's public health officials integrating all this information from birds, mosquitoes, environment, human cases to assess the real-time risk and communicate effectively with the public about prevention measures.
A much more coordinated effort.
Exactly. It requires collaboration and data sharing across all these sectors. The U.S. government, for instance, explicitly calls for this integrated One Health approach in its national strategy for vector-borne diseases. It's about shared responsibility and holistic understanding.
So what does this all mean for us, the listeners? It sounds like a really fundamental shift from being reactive waiting for people to get sick to being proactive.
Precisely. That's the core idea. Instead of waiting for a human infection, or even an outbreak, to trigger a response, the One Health model aims to monitor the entire system, environmental conditions, animal health, vector populations, for signs of instability or increasing risk. So, for example, meteorologists predict a particularly hot, wet season is coming. Wildlife biologists detect an uptick in virus circulation in local birds. Vector control teams find rising numbers of infected Culex mosquitoes. With that integrated picture, public health authorities can then preemptively ramp up vector control measures, target breeding sites, and issue public warnings before a significant number of human cases occur.
Trying to get ahead of the curve.
Now, this proactive integrated stance is certainly more complex to implement. It requires robust surveillance systems, integrated data platforms, a workforce trained to think across disciplines. However, it's arguably the only approach that is sufficiently resilient and adaptive to cope effectively with the complex, interconnected, and rapidly changing threats posed by mosquito-borne diseases in the 21st century. You could say it's the necessary antidote to those systemic failures we discussed earlier, the failures that continue to allow the mosquito to hold the tragic title of the world's deadliest animal.
We've covered a lot today. We've unpacked how these mosquito-borne diseases represent a truly amplified threat, really driven by these huge global forces like climate change, urbanization, human mobility. We've seen how our conventional tools like insecticides are struggling against evolutionary resistance, and how exciting new biological controls like Wolbachia and crucial vaccines face their own significant uphill battles. And those recent crises, the devastating dengue epidemic in Brazil, contrasted with the success in Niterói and the warning shot of local malaria returning to the U.S., they serve as such powerful real-world reminders that no nation is an island in this interconnected world.
It really leads us to wonder, doesn't it? Given the sheer complexity and the deep interconnectedness of this challenge, what part do you, listening now, potentially play in fostering a more resilient future? How does understanding this biological arms race, this interplay of environment, equity, and disease, maybe change your perspective, whether it's on large-scale global health initiatives or the importance of local public services like waste management and vector control in your own community, or even just simple environmental stewardship?
Yeah. Maybe the next time you see a puddle of stagnant water, or hear about urban planning debates, or consider the impacts of climate change, perhaps you won't just see water or buildings or weather. Perhaps you'll see a potential battleground in this ongoing, critical global health war. Because the fight against the world's deadliest animal isn't just about mosquitoes. It's truly a fight for our shared health and our shared future. And it clearly demands innovation, collaboration, and a much more holistic One Health approach.
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.